Welcome to NU 623 Adult Healthcare Unit 8, Presentation 1. This unit is going to cover prostate disorders. I ask that you read the corresponding part of the chapter for additional and required information. This presentation is meant to be an adjunct to the textbook. They are not comprehensive, rather a brief outline of selected material. Additionally, I would like for you to review any course links in your module. BPH, or nodular hyperplasia of the prostate, is one of the most common benign conditions for men over 40. Patients can present with the following subjective symptoms, such as frequency, nocturia, weak stream, hesitancy, intermittence, or incomplete emptying and urgency. The severity of symptoms can be scored with the American Urological Symptom Score Index. A score of greater than 7 usually requires more workup. You can refer to page 750 in your textbook, table 49.1. Objectively, a digital rectal exam finding would include an enlarged prostate gland, measured and documented by finger breadth size. For example, a 1 plus is 3 fingers across, 2 plus is 4 fingers across, 3 or 4 plus will have encroachment of the anterior pelvic outlet and rectal wall. There are 3 categories of possible differentials: bladder outlet obstructions, non-obstructive etiologies, and irritative symptoms. You can also refer to chart 49.1, page 751 in your text for examples in each category. So to work this up, first perform a UA to look for an infection, hematuria, or elevated urine pH. A urine culture may be positive for bacteria. If life expectancy is greater than 10 years, you will also want to do a PSA. A normal value in BPH should be less than 10. Urine cytology is done to rule out cancer, especially when there is hematuria. Intravenous pyelogram can also show an enlarged prostate. Any subsequent diagnostics can be done by urology. A conservative approach of watchful waiting is done for mild to moderate symptoms with no changes in the urinary tract, and there is little impact on lifestyle as long as more serious conditions have been ruled out. Symptom control is done by avoidance of bladder irritants, such as avoiding caffeine, alcohol, highly seasoned foods. Also avoidance of alpha-1 adrenergic blockers, such as terazosin or doxazosin. These can cause hypotension, so you need to advise your patients to use them at bedtime. Tamsulosin or alfuzosin target BPH and cause less hypotension. Another class that can be used is the 5-alpha reductase inhibitors, but these can take up to 6 months to reduce the prostate gland. Because this class can reduce PSA levels by 50%, there is a chance it can mask prostate cancer detection. Combo therapy with both classes is sometimes needed. A newer treatment includes the PDE5 inhibitor, Cialis. Complementary therapies can be used as well. Please refer to page 752 in your textbook, table 49.1. Transurethral resection of the prostate, or TURP, is needed when the AUA score is greater than 8, and evidence of urinary retention, obstructive uropathy, recurrent UTIs. For moderate to severe symptoms with a small prostate, a transurethral incision of the prostate can be done. For very large prostates, an open prostatectomy or robotic simple prostatectomy can be done. Less invasive procedures include transurethral laser-induced prostatectomy, transurethral electrovaporization, microtherapy, needle ablation, high-intensity focused ultrasound, and transurethral balloon dilation and stent placement. You can read the details about each of these procedures in your textbook on pages 752 and 753. The AUA symptom index can be done either by the PCP or the urologist every 1 to 6 months. Urodynamic studies are done routinely to check flow rates and voiding pressures in the urologist's office. Digital rectal exams can be done by either provider. The American Cancer Society does not recommend routine screening of PSA due to overdiagnosis and inappropriate treatment. If a man wants a screening and the PSA is less than 2.5, he should be retested every 2 years. If it's greater than 2.5, you need to retest yearly. Referrals for BPH will go to urology for specialized testing and suspected cancer or urinary retention. Prostatitis can be acute, chronic, non-bacterial, which is the most common, prostatodynia, or asymptomatic inflammatory. This occurs mostly in sexually active men ages 30 to 50 years old. You can review the common subjective symptoms that correspond to the different types of prostatitis in your textbook on page 755 under Focus on History. Tenesmus is the recurrent desire to empty bowel and bladder with pain and involuntary straining. Objectively, your digital rectal exam will likely show a tender, boggy prostate. But with chronic bacterial prostatitis, it may be normal. Be careful not to vigorously manipulate the prostate, as it can cause bacteremia or septicemia. The presentation of acute prostatitis can mimic other disorders, so a careful rule-out is very important. A CBC will show leukocytosis and a left shift if it is bacterial prostatitis, and a UA will show bacteriuria, pyuria, and likely hematuria. Sexually transmitted infections are a common reason for prostatitis, so you will want to be sure to get a UA for gonorrhea and chlamydia. Non-bacterial prostatitis will show white blood cells, but the urine culture is going to be negative. Prostatodynia will not have any abnormal labs. A CT or transrectal ultrasound is done if malignancy or abscess is suspected. A needle biopsy may be done by the urologist. First-line treatment for bacterial prostatitis is antibiotics. Acute presentations are generally treated for 2 to 4 weeks, while chronic infections will require 4 to 6 weeks of treatment. Non-bacterial treatment is mainly supportive care. You will want to advise your patients to avoid bladder irritants such as alcohol, caffeine, and spicy foods. In certain cases, based off of the white blood cell count of expressed secretions, an antibiotic might be used. This would likely be initiated by the urologist. NSAIDs can help with either type of prostatitis, for pain, inflammation, and to alleviate bladder spasms. If there is urinary retention obstruction, urinary catheterization may be needed. Your text will tell you only a suprapubic catheter should be done, but newer thinking states a urethral catheter on a temporary basis is acceptable. Referral to the hospital is necessary if the patient is acutely ill or with fever or urinary retention. Patients may have an abscess, urosepsis, or urinary retention. Follow-up depends on the type of prostatitis and the patient's response to the treatment. For acute issues, a UA or urine culture should be done a month after treatment. For chronic prostatitis, a UA and urine ultrasound should be done every 30 days until it is cured. Patients may require prophylactic antibiotics for recurrent infections. Refer to urology for those with hematuria or very elevated PSA, or if you suspect cancer. You should also refer to a hospital for acute urinary retention, urosepsis, if a patient is acutely ill, if you suspect an abscess, or with a fever. Be sure to read about chronic pelvic pain in men, which is also known as prostatodynia, on page 684, chapter 46. This is an umbrella diagnosis as the cause is unknown. There is no evidence of active bacterial prostatitis. Some think it is equivalent to non-bacterial prostatitis. You may see it more in chronic prostatitis in men over 50, but the evidence points to a non-prostatic cause. However, it is often mistaken for chronic prostatitis. Subjectively, you will see low back pain, perineal or pelvic pain, urinary hesitancy, interruption of urine flow, with no history of urinary tract infections. Objectively, the prostate exam is normal. For differentials, you are basically just ruling these out. A UA, PSA will be normal. Urodynamic testing can be done if a patient doesn't respond to medications, but there is no test to specifically diagnose this disorder. Supportive care treatments include alpha blockers to reduce bladder, neck, and urethral spasms, myofascial release therapy, biofeedback for pelvic floor dysfunction, warm sitz baths, diazepam as a muscle relaxer, and psychotherapy if accompanying sexual dysfunction. Please see page 685 in your text for resources on patient education. Follow-up will be variable based on a patient's need, medication tolerance, and any adjustments. You should also consult urology. Onset of prostate cancer typically occurs in men ages 50 to 60 years old. They can typically be asymptomatic in early stages, but can also be asymptomatic as the disease progresses. You can see systemic symptoms such as bone pain, weight loss, anemia, shortness of breath, lymphedema, lymphadenopathy, inability to perceive touch, pain, or temperature in the perineal scrotal area, and urinary retention. The neurologic symptoms suggest spinal cord involvement. Objectively, the prostate will be hard, nodular, or indurated. This can be localized or diffuse. In late disease, you will see hematuria. The bulbospongiosus reflex can be used to evaluate a lesion in the spinal cord by viewing contraction of the rectal sphincter in response to squeezing the glans penis. The possible differentials are BPH, benign nodules, prostate stones, nodular whorls, or seminal vesicle enlargement. Of these, BPH should be the first thought due to the similarity of symptoms. Please read the section on diagnostic reasoning in your text so that you will understand the American Urological Association and American Cancer Society's recommendations for PSA screening. There is no level of a PSA that definitely rules out cancer, but the risk increases as a PSA increases. A PSA level of 4 is a common threshold for considering a biopsy, but serial PSAs are thought to be more accurate because persistent elevations are more concerning. If a PSA is above 10, cancer is suspected and the patient should be referred to urology for a biopsy. If cancer is found, then subsequent tests for METs should be done. Tumors are staged using the Gleason system from 1 to 10. 1 to 4 is slow growing, 5 to 7 is moderately differentiated cancer, while 8 to 10 is aggressive and rapidly growing. Further staging follows with more detailed categories called the tumor node metastasis system. Localized disease can be managed by chemo, radiation, and surgery, but if the cancer has spread beyond the gland, it is fatal. Palliative care is only offered in this situation. Surgery may include radical prostatectomy or orchiectomy for patients under 70. Cryosurgical ablation of the prostate is another possible therapy. Hormonal therapy, alternative hormonal preparations, and anti-androgens is also used to deprive testosterone in an effort to inhibit cancer growth. Follow-up is determined by the specialist, but for the first year they should be examined every 3 months and have a chest x-ray and bone scan every 6 months. Then imaging is done only once a year. A primary care provider should provide health maintenance and follow lab testing. Potential complications to watch out for are cardiac failure, phlebitis, pathological fractures due to testosterone suppression, as well as others mentioned in the management section of the text. Immediate referral to a urologist if prostate cancer is suspected, either by subjective or objective findings. The urologist will typically refer to a cancer specialist.